Thank you, Chairperson. First of all, I'd like to thank our GVK sir for giving this great opportunity. A wonderful PG talk from our Dr. Neo. It's a great talk. So friends, we all know that previous talk is emergency medicine. Now we have the talk which is very essential for our clinical practice, skin and diabetes. First of all, you should know, skin acts the dynamic metabolic shadow, whatever may be the diabetes, maybe pre-diabetes or ongoing diabetes or uncontrolled diabetes. In simple, skin is the largest and most commonly affected organ in diabetes, which have been contributed by the metabolic dysregulation, microscopic complication, and immune dysfunction. But if you see a diabetic patient, it may proceed with the diabetes onset, or it may ongo with the diabetes complications, or also it may follow the diagnosis of diabetes. Also, we see a lot of patients with pruritus or itchy skin or dry skin like that, becoming any baronitis, baronoposthitis, vulvitis, vulvo itching. So these are the lots of problems we can see in our clinical practice. Skin is the mirror in diabetes, one of the earliest signal organ of dysglycemia. So it acts as a visible window to the invisible, the word is invisible metabolic dysfunction of any form, right from the hyperinsulinemia, insulin resistance, and also ongoing diabetes. Prevalence globally, high prevalence is there, but in diabetes, almost 30 to 70% of the diabetic patient in both type 1 diabetes and type 2 diabetic patient, they have this burden. Among that, 20 to 30% of the patients may have the skin signs. Chronically, they will have even with the controlled diabetes due to immunodysregulations. There are possible, these are predominant predisposing factor contributed by metabolic factors, vascular factor, neurological factor, immunological factor, and external factors. Friends, this is a single slide which enumerates everything, what are the possible skin manifestations in diabetes, both type 1 and type 2 diabetes. Simple classification, I give the snapshot. Infection, maybe bacterial, fungal, or virus. Non-infectious, inflammatory, I give everything, the huge classification that right from diabetic dermopathy to pruritus, cirrhosis. And what are the manifestations? A lot of patients we see in our clinical practice, acanthosis aggregans, or any skin tags that manifest the insulin resistance. Vascular disorders like a lot of patients we see the diabetic foot syndrome, necrobias lipidica, one of the dreadful manifestations of skin in diabetes. Bullous diabetes also is very, very important, and also some miscellaneous form of diabetes, including the vitiligo, eruptive, and drug-induced diabetes. Drug-induced diabetes also comes under this classification. These are the common skin conditions that we see in a clinical practice among the diabetic population, like hardeolum styes, carbuncles, infected skin around the eyes, folliculitis, boils, fungus infection, tinea, candidiasis, severe itching of the skin, and acanthosis aggregans. The possible pathophysiology is age, advanced glycation activation, oxidative stress, and hyperactivity of the polyol pathway, which is going for the impaired immunity and neuropathy, and thereby having the impact on the skin barrier dysfunction that contributing for the keratinocyte failure, and also it decreases the nutrient of the skin, and thereby leading to infection, dermatosis, as well as the poor wound healing. I just enumerate the simple common skin manifestations in diabetes. This is one of the common diabetic dermopathy, which often occurs in the lower limb shin spots. Is associated with the microangiopathy like neuropathy or nephropathy, retinopathy. And one of the commonest things that we see of late in most of the patients as a part of obesity patients or insulin resistance patients or the diabetes patients is a marker for the insulin resistance. And it is hyperinsulinemia, insulin activates this insulin growth factor 1, and thereby contributing for the dysregulation in the keratinocytes and also the fibroblast. And diabetes with obesity or diabetes, most of the patients we can see as a skin tag, but skin tag also is one of the common finding in our clinical practice. Whenever you find a skin tag, maybe around the neck, maybe in the axilla, you think about the insulin resistance. Necrobias lipidica is one of the dreadful things because these are more prone for the squamous cell carcinoma. This is more seen in both the type 1 diabetes and type 2 diabetes, central ectopy, as well as the telangiectasia. Bullous diabetic orb is non-painless, but it have the sudden painless blisters, both feet and hands are common. Heel without carrying, both common in type 1 diabetes, type 1 and type 2 diabetes, and also most predominantly in all form of microangiopathies. Cirrhosis also we can see like dry skin, scaly skin often associated with itching and due to the autonomic involvement of non-sweating and dehydration. Most common, very most common, candidiasis, tinea infection, scalp seborrheic dermatitis, mucormycosis. In COVID time, we have seen lots of patients mucormycosis going for more and high mortality fatal rate. This is more and more complicated in diabetes population rather than in non-diabetic population. Bacterial, of late we see furuncle, carbuncle, cellulitis, abscess formation. The predominant organism, Streptococcus, Pseudomonas, and Staphylococcus aureus. Diabetic food syndrome, we have a huge session here in diabetic food that we can learn from that also. So sensory involvement, motor involvement, autonomic, and along with the vascular, this is contributing for more and more in the prevalence of diabetic foot syndrome. Now we have more and more patient education programs there, therefore the incidents are also coming down that we have to empower the patient. Vitiligo, autoimmune, more common in type 1 diabetic patients. Immune system destroys the melanocytes, insulin cells, and thereby surge the inflammatory marker cytokines. This also contribute for the vascular inflammation and early onset of the cardiovascular burden. Dixon planus is one of the aggressive manifestations in skin with diabetes patients, and it acts as an immune dysfunction and T-cell autoimmune. Granuloma annulare, once again significant both in type 1 type 2 diabetic patients. Ring-shaped lesion looks like fungus infection, but is granuloma annulare, skin colored and circular annular plaques. And also this contribute for both microangiopathies in the form of neuropathy as well as the retinopathy. So today we had a wonderful session by our Dr. Sunil Gupta sir regarding the insulin errors. So this also should be keep in mind. Our giving medication for the diabetes also will have the problem of the skin problem, insulin related lipohypertrophy, lipodystrophy and lipoatrophy. And some more we'll think we have heard about the incretins based Pempigo and also SUs, that is any glimepiride or gliclazide. Those patients couldn't be able to tolerate the SUs, the sulfonamide ring is there. They're having they will land up in Stevens-Johnson syndrome. And after we see more cases on the genital fungal infection with the SU, especially dapagliflozin, empagliflozin. And any patient with the CGM or carrying with the pump, CS2 pump, they will be having the contact dermatitis that also we have to see, and also we have to treat the patient because they may land up in abscess formation, cellulitis formation, and other complications. Diagnostic approach, we have to do the thorough clinical examination. Clinical examination plays an important gold standard vital role in our practice, that is should not miss. And glycemic profile is important because glucose control is the centricity of this problem. Skin biopsy, that we have to refer to the dermatologist and get the proper opinion for the further proceedings. These are the pillars. Glycemic control, because glucose control is the centricity of the skin problem management with diabetes. Topical therapy, we know that systemic therapies with some antibiotics, antifungal, and antiviral in this one, any chicken box like lesion. Wound care, proper wound care, and patient education is very, very important for the hygiene. Proper hygiene also important. So these are the red flags when we have to get alert, when we have to get referred to other opinion like dermatologist, surgical opinion. So any patient skin problem with diabetes, having the non-healing ulcers, any having the rapid spreading of infection, black discoloration, especially gangrene, severe pain or swelling, going for more and more cellulitis, and systemic involvement because this skin manifestation complicating the other systemic problem like any skin manifestation of acute glomerular nephritis, also one of the problems that may be always included. So diagnosis in diabetic skin disease is not just identifying the lesion, it is uncovering the underlying metabolic and systematic status. So my dear friends, to conclude, the skin is a mirror of diabetes, should not miss the diagnosis. Always early screening, early diagnosis, and early treatment is very important in our clinical practice, revealing its presence, severity and complication. Cutaneous manifestation in diabetes is not merely cosmetic, but clinically significant indicators of metabolic control and systemic involvement, early identification and integrated management, especially by we are clinicians. We should join hands with the other consultants, including dermatologists, and we should find the diagnosis and apply the prompt treatment, recognize early, treat effectively, and prevent the complications. Thank you very much.